I'm going to analyze another clip from the Pitt. As I've said before, this is a very good medical show that really dramatizes what it's like in the emergency department with some dramatic license, of course. And in this one, I'm going to talk about a case I think that's pretty common. It might seem boring, but it's actually pretty important when it comes to how we think about treatment of infectious disease.
Pain here, Mr. Lee?
Can't feel a thing.
Great.
Where's Santos?
Probably catching up on our charting.
Right.
Lights out. What's the lamp on? Okay.
I might want to use some of that on Halloween.
That is 250 cc's of sterile saline with one small touch of a sterile floor strip.
So, what we're seeing right now is an evaluation to determine whether a person's lower extremity injury has penetrated the joint, if it's kind of more severe than what it looks like. And they're doing that by injecting fluorescent saline that will light up with a special lamp. And the reason why they're doing that is if that joint space has been breached by this trauma, that could introduce a risk for infection because now the environment is communicating with that joint space, and that may change the way you manage this because it's going to have been contaminated and may need surgery, may need prolonged courses of antibiotics. All of that is going to be based upon how deep this injury goes.
We are going to inject this fluid into your knee, Brandon, and if there's anything glowing in your wound, we know we have a leak.
Feeling some pressure.
Yeah, it's normal. As soon as I finish the test, I'll pull off the fluid.
That looks good. Laceration did not enter into the joint space.
Surgery not needed.
So you're seeing that they don't see any fluorescence emanating, which means the laceration did not enter the joint space, as Dr. Robbie says, which means they're not going to need a major surgical operation to clean out the contamination.
Excellent. I can get back to the parade.
No, we'll still need to stitch you up and splint your wrist.
Hanging a gram of Ancef. Wait, he has a penicillin allergy. No, PenFast was negative. We're okay.
Now they're going to give antibiotics because this is a contaminated laceration where you want to prophylax it so that it doesn't become infected. And you hear them say they're going to hang 1 gram of Ancef. Ancef is the brand name for cefazolin or cefazolin. Some people pronounce it either way. And that's a cephalosporin antibiotic. Cephalosporin antibiotics are a big class of antibiotics. Probably most of you have had a course of Keflex, for example. That's a cephalosporin. Cephalosporins are part of a wider class called beta-lactam antibiotics. Beta-lactam refers to the chemical structure, a special ring that's in the chemistry. And the original beta-lactam drug was penicillin. So now they're saying he's penallergic. So what they're saying here is that because this patient has reported a history of penicillin allergy, they're being cautious or wondering about giving cefazolin or Ancef because they're sort of in the related class. Now, that cross-reactivity is about 2%. So people who are truly allergic to penicillin are about 2% of them are going to be allergic to cephalosporin class antibiotics.
Hanging a gram of Ancef. Wait, he has a penicillin allergy. No, PenFast was negative. We're okay.
They mentioned the patient's PenFast score being negative. So PenFast is a quick clinical scoring tool that you can use to determine whether or not someone's allergic reaction to penicillin is worrisome, is a true allergy. And it's a couple things. Has it been 5 years or more since your reaction? Did you have anaphylaxis or angioedema, which is anaphylaxis is low blood pressure, kind of going into shock. Angioedema means swelling of your lips, your tongue. Did you have a severe cutaneous reaction or a skin reaction? And did you require treatment for your reaction? So based on that, you can determine, does someone have a low or a high risk of having a true penicillin allergy? And that's what they did in this case. And as I've said, sometimes you have to do a skin test or desensitize someone if they have a true allergy or have some diagnostic uncertainty whether or not it's a real allergy or not. Now, the thing is, when you look at the population as a whole, about 10% of the population say they're allergic to penicillin. But of those, 90% plus are not true penicillin allergies. They are, for example, gastrointestinal upset. So somebody gets nausea or vomiting. That's not an allergy. Or they don't feel well. An allergic reaction is a specific immunological phenomenon, and it's characterized by hives, shortness of breath, swelling of the lips, swelling of the throat, difficulty swallowing, and in the worst cases, anaphylaxis, or basically cardiovascular collapse. That's what an allergy is. A side effect of a drug, like you get a headache or you get nauseated, that's not an allergy. But what happens are people get these things labeled on their chart, and then no one wants to give them penicillin. And you might ask, why does that matter? Is it there's so many different antibiotics, they can just get another one. For most of the infections that we treat, if something is sensitive to penicillin or penicillin class antibiotics, beta lactam antibiotics, that's going to be the treatment of choice. If you're labeled with a penicillin allergy, true or false, you will end up getting second line antibiotics for everything and basically get inferior treatment. Those individuals, for example, have worse outcomes when it comes to surgical site infections because they're getting prophylaxis with a second line agent. So there's been a key effort to try and demystify penicillin allergy and to delabel penicillin allergies in charts so that people can get that class of drugs if they don't have a true allergy. And usually you can figure that out just by asking the patient. And they might say, oh, I had nausea and vomiting. And say, that's not an allergy. You take it off the chart. Sometimes you get these crazy stories like, my grandmother told me when I was a child, my throat swelled up when I got penicillin, but it might have been my cousin. She can't remember. That's a true story from a patient. Those you can kind of demystify. You can delink that penicillin allergy pretty easily. But some people might have said they got a rash or they had difficulty breathing. And there you might have to do more work, which might mean looking to see had they ever gotten a penicillin class antibiotic after that point. Is it documented in the chart somewhere? And if they did, you're probably safe to give it. Or can you do a skin test to see if they react to it? And then if they don't, you're probably safe to give it. Or you can actually desensitize people by giving them escalating doses until they get to the treatment dose. But part of this is trying to make sure you're getting it right because these drugs are so important. Penicillin was the first antibiotic really discovered by Alexander Fleming, and it is still one of the best antibiotics. That class is the best when you can use it. And there's always this kind of saying, beta lactams are best, and that holds true. So if you can give a penicillin class antibiotic and remove an erroneous allergy label, you're doing good for the patient, you're doing good for antibiotic stewardship, and you're doing good for the treatment of infectious disease.
My mom said I got a rash with amoxicillin when I was 2.
Yeah, probably not a true allergy. Go ahead and give it, Kim.
The patient is saying, my mom said I got a rash to amoxicillin when I was 2. So that's a common refrain you might hear. Amoxicillin is related to penicillin. It's a beta-lactam antibiotic, and rashes are common in children when they're 2, whether or not they're on an antibiotic or not. They might have gotten antibiotic prescribed for some kind of upper respiratory tract infection that goes with the rash, and they had the rash anyway, and they blamed it on the amoxicillin, and it wasn't a true allergy.
But have epi and Benadryl standing by, right?
Yes, to be on the safe side.
Now, the medical student is saying have epi and Benadryl standing by. That's epinephrine and Benadryl or diphenhydramine. That's in case there actually is a real allergic reaction. So you can intervene quickly and reverse it with epinephrine or adrenaline. That's what's in an EpiPen, or Benadryl, which is an antihistamine.
Most people who think they have a penicillin allergy actually don't.
Always listen to the nurses. They run the ER. We just try and stay out of their way.
So the nurse here is saying what I just had been talking about, that most people who think they have a penicillin allergy don't really have a true allergy. So what that illustrates, this case illustrates, is how important it is to know your allergies and to actually decipher what they actually meant. And if you're a patient and you've got a penicillin allergy, you've been told that, why not investigate that and ask around and try and figure out what that actually means? And if it's not really a penicillin allergy, get it off of your chart, because you're going to end up getting second-line antibiotics and having worse outcomes if you're labeled for life with a penicillin allergy that's not truly an allergy. But if you actually have a real allergy where you got swelling of the throat, anaphylaxis, bad rashes and hives, that's a different story. And you need to be really proactive when people are giving you antibiotics to make sure that you're not going to get a reaction. But the point is that most penicillin allergies are not true allergies, and we can safely give those drugs to people and they get better outcomes for it.